Hey guys, this is Dave Mitro. I'm a professor of anesthesiology and I'm also the residency program director here at the University of Pittsburgh. I am going to be giving you a talk for your basic exam on ethics and medical legal issues. This is kind of a catch-all lecture that used the keywords and content outline that didn't fit into other presentations. But don't skip over this because there are some easy points to be had in these areas that I think you should listen to. Sit back and just get the key topics and hopefully you can pick up 2 or 3 questions. Hopefully it's not the difference of passing or failing the exam for you, but if it is, I'm glad to do it. I have nothing to disclose. As in my other lecture, if the words are in red, that means it was either a content outline word or a keyword from the ABA basic exam. So I would pay close attention to those. So the first keyword would have been ethics and advanced directives. And let's talk about advanced directives. They allow a person to document their wishes at the end of life. So you have an advanced directive. This tells your physicians what you want to have done to you. In order for these advanced directives to be in place, 2 physicians have to certify that the restrictions for the advanced directive are in place. And what that means is that, number 1, the person is unable to make decisions. And number 2, the conditions stated in the directive are met. And those can be things such as terminal illness or permanent unconsciousness. Advanced directives do not expire, so you do not need to renew those, and they are in effect until they are changed by the patient or their representative. And these are different than DNR orders, which are do not resuscitate orders. A DNR is a medical order written by a doctor instructing healthcare providers not to perform CPR if the patient arrests. DNR orders are specific to CPR and not for other treatments such as nutrition. A keyword was suspended DNR, so I put a question mark after that. So not knowing what they're going to ask, the way to describe this is you can't just assume that a patient's DNR is suspended when they go to the operating room. This is a discussion you must have with the patient or their surrogate, and you should get this information in advance so that you know what the patient's wishes are. To further clarify or to further separate out the difference between advanced directives and DNRs, a DNR may be guided by the advanced directive of the patient, but they are not the same thing. Keeping along with ethics, we have patient privacy, which is a keyword. And the most important part of patient privacy, or the most important thing that you could be tested on, would be HIPAA, and that's a Health Insurance Portability and Accountability Act of 1996. And there were 2 titles to that. Everyone remembers the privacy part, but there were actually 2 titles. Title 1 talked about access to health care, access to the records, portability of records, and renewability of insurance. Title 2 was to prevent fraud and abuse, including patient privacy, simplification of the administrative process of insurance, and also medical liability reform. So the HIPAA privacy rule regulates the use of protected health information by everyone it covers. That includes you as a provider, your plans, health plans, clearinghouses, insurers. So it covers everybody. And personal or protected health information is any information concerning the health status, the provision of care, or the payment for care that can be linked to an individual. Computer security was a keyword under this section. So please remember that having patient information on your computer is no different than having patient information on paper. You cannot share your computer with patient information there. You'll know from most of your hospitals that you're working at, any patient data or access to patient information is a heavily secured area, encrypted area, and that is why, because of this HIPAA privacy rule. If a patient asks for their protected health information, you must be able to provide that within 30 days of their request. As far as punishments for breaking HIPAA, it's punishable by fines, and it even can be punishable by imprisonment, and that depends on the severity or the intent. So if releasing someone's health information was done for a malicious purpose, that could be imprisonment for that individual. Moving on to informed consent. Informed consent is the process of getting permission from the patient or their surrogate or their guardian before a healthcare intervention. If a person is unable to give consent, another person is generally authorized to do so on their behalf. When we're talking about medical care, the agreement of consent is usually done by a signature. And I want to clarify, a signature shows that the informed consent process has occurred, or documentation that occurred. But the signature itself is not the informed consent. It is the process of giving the person the information and allowing them to make a choice on what they're having done. In an emergent, life-threatening situation, you may waive the informed consent. So there are three components to informed consent. Those are disclosure, capacity, and voluntariness. For disclosure, the patient must have all the relevant facts. Capacity means they have to have the ability to understand and evaluate their situation. And voluntariness means there can't be coercion in making a decision. So I told you this kind of hodgepodge lecture, and I was looking for a good segue, and I couldn't find one, so here's me on a segue, guys. I don't know where that is. It looks like, could be Texas, could be Rome, I have no idea. So let's talk about patient safety. I'm going to give you some definitions here. First is a medical error. A medical error is a preventable adverse effect of care, whether or not it is evident or harmful to the patient. So an example here, you have a patient in the hospital with congestive heart failure, and they get a normal meal instead of a low sodium meal. That is a medical error. It may or may not be harmful to the patient, but it's an error. When we talk about effects, we can label those different ways. First is an adverse event, and that is an undesired, harmful effect resulting from a medication or other intervention. Or we could have a sentinel event. And a sentinel event is an unexpected occurrence involving death or serious physical or psychological injury or risk thereof. So let's talk about a sentinel event. So an example of a sentinel event would be surgery on the wrong body part. So if that does occur, accredited organizations are encouraged, but they're not required to report any sentinel events to the Joint Commission. When they are reported, when you do so, it's expected that a root cause analysis is done within 45 days. You are required to notify the FDA and device manufacturers within 10 days of sentinel events caused by medical devices. To just drive a point home for you guys, the terms sentinel event and error are not the same thing. Not every sentinel event occurs because of an error, and not every error results in a sentinel event. So separating those out in your mind can pick you up one of these freebie points that I'm talking about. I mentioned that JCO requires a root cause analysis done when there's a sentinel event. And what that is it's a method used to analyze adverse events. And it identifies what, how, and why something happened. So to be effective, there's different strategies for this, but to be effective, This analysis should establish a timeline to show causal relationships. And what you're trying to identify is the root cause, which means if you remove this part from the sequence, the adverse event will not recur. On patient safety, one of your keywords was medication errors. And there's many kinds of medication errors. Most common for us would be a syringe swapper. That's actually the incorrect medication being given in for anesthesiologists. It's going to be a syringe swap. But it could also be the wrong dose, meaning you give too much of a medication, or omission, meaning you give too little or none. And those are all medication errors. It's very difficult to determine the incidence that this occurs in anesthesiology, and there's been different studies looking. A study out of New Zealand that probably is one of the better ones done showed that there's been an error for every 130 anesthetics. If you look at the other studies done, they tend to confirm about that order of magnitude. This doesn't mean that they're major medication errors causing adverse events, but they are medication errors. If you do make an error, I'm going to talk now about disclosure of errors to the patients. The AMA, American Medical Association Code of Ethics, says that it's a fundamental ethical requirement that a physician should deal honestly and openly with patients. Patients have a right to know their past and present medical status and be free of any mistaken beliefs concerning their conditions. The physician is ethically required to inform the patient of all the facts necessary to ensure understanding of what has occurred. So disclosure is an important part, and the AMA says that we are ethically required to inform the patient. People are afraid sometimes to disclose errors to patients. However, studies have shown that patients' perceptions of mistake depend upon the timeliness and the quality of the disclosure that was brought to them. Studies have shown that disclosure decreases lawsuits against the physician, and that an apology is okay in those situations. When it comes time about disclosure of the error to the organization, accreditation agencies encourage the reporting of adverse events to correct system failures. So reporting events can stop them from happening again, and that's why everyone is so encouraging of reporting things. Any QI systems should be focused on improving the quality and efficiency of patient care while being fair to the caregivers. Segue back the other way. Moving on to professionalism and licensure. Licensure is required to practice in any restricted field. So medicine is a restricted field, which means you need a licensure. You need a license. Licensure is state specific. So I am licensed to practice in Pennsylvania. That doesn't mean I can go do that in Texas tomorrow. Most states and specialty societies have professionalism, a requirement of professionalism for part of their licensure or certification. So professionalism is a section on your application and for renewal of medical licenses. So when we talk about professionalism, which was a key word, those come from, we always have known about professionalism, but the core competencies, which were established by the ACGME, established 6 areas that were named as a guideline to ensure U.S.-trained residents receive a complete education. You guys know these, you've been training. You know that the 6 competencies are patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. So professionalism is a core competency required for your licensure. It's an important component of your career.